I'd like to go ahead and introduce or reintroduce Dr. Joyce Liao, who will be our next speaker. As you know, she is the director of the Optic Distrusion Center here at Stanford, and she's a professor of ophthalmology and neurology. She serves as our director of the neuro-ophthalmology and co-director of our vision research training program here at Stanford. She's dedicated her research to basic science and translational research in optic dystrusion. And above all, she's been a fabulous mentor to many of us, including myself. So please welcome Dr. Liao, who will speak on FOSS autofluorescence imaging of optic disc drusen. Thank you, Joyce.
Thank you, Dr. Barris, for that kind introduction. Let's see if we could figure out all the technical details. Yep, I'm mostly on camera. All right. Thanks, everyone. I'm going to talk about multimodal imaging with the emphasis on autofluorescence imaging. I have no commercial financial disclosures. So the objective for this talk is to, one, learn what optic dystrusion look like in different on-FOSS ophthalmic imaging techniques. Two, know the most sensitive on-FOSS ophthalmic imaging technique. So the gold standard is the enhanced depth imaging, optical coherence tomography, but what else can you use? And then third, learn what optic dysedema look like, the so-called ODD-AION on FOSS imaging. So optic dystrusion, as Dr. Hammond mentioned, are calcified deposits at anterior optic nerve. They have this brightly autofluorescing appearance and a hyperechoic appearance on ultrasound. This is a slide that you saw earlier, just illustrating the multiple different on-FOSS ophthalmic imaging techniques that we use routinely. What's not featured here is multicolor, ocular metabolic imaging, and others. So this is a 23-year-old left eye of a woman with bilateral optic dystrusion. She has a lumpy, bumpy appearance of the optic nerve head. And if you follow the red arrows across the different images, you can see that they correspond to discrete deposits on the surface of the optic nerve, and the white correspond to the white ones. So in this patient, it's typical that you have a superior and nasal predominance to the drusen deposition. We don't know why exactly, but it could be related to eye movement, so biomechanical injury to the optic nerve axons as is making a 90-degree turn at the optic nerve head. There is some thinning of the OCT retinal nerve fiber layer, and if you take a slice, there we go. You can see the B scan on the lower right, a single drusen deposit corresponding to the about 11 o'clock location on the disc itself. So you get these on-FOSS imaging instantly, basically. As soon as the picture is taken, you see the entire nerve, but with greater sensitivity than a color from the photo, which is equivalent to a physician's examination. You don't need to review the B scan slice by slice to do a mental reconstruction of the drusen deposition. This is a patient with autosomal dominant familial optic dystrusion. You can see that the right eye is relatively flat appearance. There is some deeper drusen deposit, but from a surface, you look at it, you really don't see anything. And on the autofluorescence imaging underneath it, you also really don't see much. Now, in contrast, the left eye, which clearly looks full and blur, this margins are blurred. You wonder if it's swollen. So that's a very typical appearance of a case of severe drusen. And on autofluorescence imaging, you can see that the entire optic disc is bright, but it's brightest in the nasal portion, following that superior nasal predominance. On OCT scan, comparing the two eyes, you can see that there's a fairly deep, meaning below the buccal membrane opening, large drusen deposit. And then the picture to your right, you can see a moderate one with these decorated hyperreflective lines. There is a large fons in the nasal portion just above the yellow pointer. So these are characteristic features looking at en face imaging and the OCT correspondence. This is the family tree for this particular patient. The patient illustrated is in the second generation, patient number 1. Her sister, you can see the olive fluorescence imaging to the right. You can see mainly an inferior hyperautofluorescent deposit and a gentle glow to the entire disc. That's a little difficult to be sure, is that real or not? Their mother, which is the image, autofluorescent imaging above, you see the disc is typically dark, which is the normal appearance of the optic nerve on autofluorescence imaging. She does have some hyperreflective lines and deeper drusen deposits. So essentially the deeper, one take home is the deeper drusen deposits don't show so well on the en face autofluorescence imaging, but it sure does a decent job in terms of, you're instantly looking at it as soon as the image is taken by the photographer that this patient clearly has something going on at the optic nerve head. So let's look into the different techniques a little bit. This is a paper we published recently in Journal of Neuro-Ophthalmology, where is a different patient with severe optic dystrusion. And what's illustrated is the color, fundus photography, autofluorescence imaging, the multicolor. Both of these are confocal scanning laser ophthalmoscope, otherwise it wouldn't look so pretty. So Dr. Dubra would like to make sure I say that. And then you have the near infrared reflectance imaging in the middle on the bottom. So the wavelengths for the near infrared reflectance is essentially the same as a spectral domain OCT. So a little over 800 nanometer. And so bright things, this is also something else that Dr. Duber taught me. Things are bright on the OCT will also appear bright on the en face near infrared reflectance. So you really get a lot out of those images. You could exactly correspond the individual deposits, especially if they're superficial, from the different en face images to the B scan, although the correspondence does take some time, but it's really nice to be able to look for, is there, so the red arrow points to a small, relatively superficial drusen that's surrounded by pretty bright margins. And the red is basically pointing to the 9 o'clock position where that exact drusen is located. The yellow arrow is pointing to this area. It's kind of like a ring around the disc where there's no RPE. So you recall that the bright signal autofluorescence imaging of the retina comes from lipofuscin in the RPE. So it's very common in drusen that you lose that RPE, which you can see on the B scan in the lower left-hand corner, and you get this dark ring around the edge. On multicolor imaging, so this is pseudo color, you see a slightly more intense orangey warm ring around the disc. And last but not least, the multicolor imaging, the blue and the green reflectance imaging, I find that in patients, you could see this brightness around the peripapillary vessels, more often around the arteries than the veins. But I'm not sure exactly what it means yet. So that's one of the things that we would like to answer. So which en face imaging modality is the most sensitive in the diagnosis of optic dystrusion? We did a study looking at just the Stanford data set. So this is just a retrospective study using our pretty nicely set up mechanism called STAR. You basically look at all the patients with a particular diagnosis of optic distrusion, or by natural language processing, you could pick out notes. So sometimes it's no drusen, but you have to go through that. So we started with almost 800 specific individuals, and then narrow it down based on their diagnosis, and then a visiting instructor, Dr. Yan, review all of them. And then identify 68 eyes that had all three FOSS ophthalmic imaging modality, which is color imaging, autofluorescence imaging, and near infrared. And they had to have the EDI OCT or the OCT as a gold standard. So we looked at the pair images from 61 eyes in total with high quality, and essentially just comparing the three different types: green light, meaning a little longer wavelength, autofluorescence imaging; blue light, that's the shortest one that we use; and then near infrared reflectance. That's basically the freebie that comes with your OCT imaging. And you could see that comparing the first row going across, something is clearly wrong in every imaging modality. And then you see this mountain on the B scan. The second and the third row, you could see a bit, instead of a uniform hyper autofluorescence on the green light second column, you see that there's more drusen deposit in the superior nasal portion of the nerve. And the difference between the second column and the third column tells you roughly how much of that is superficial versus deep. So in the top row, there's quite a lot of brightness with texture. So there's good amount deep as well as superficial. In the second one, it looks fairly superficial. The green and the blue look very similar. The third row, you can see that the green is much brighter than the blue. So a lot of the drusen is deep. And then the last row, basically you don't see anything. And this is when you really need the EDI OCT to help you identify whether this patient does have optic distrusion or not. So that yellow circle on the bottom. This is another image to show you the beauty of the near infrared reflectance imaging. I really come to appreciate that because it gives me so much more texture than a regular color photo. So you can see the tiny dots on the first row of various brightness, essentially as the light bounces off. The second row, you can see they look more grayish. So it's a different quality than the first row, but it seems everywhere. So Dr. Yan has a pretty name for these things. So they look like pearls or bubbles, very intuitive feeling. And you could correspond exactly to the B scan on the right. So the summary from this study was that the green autofluorescence imaging was the most sensitive, but the blue light autofluorescence imaging, and if you train your eyes to look at the near infrared, remember it comes free with your OCT scan. It's actually quite powerful. You can see quite a lot in terms of, normally it should be black, but if there's drusen deposit, there's sort of variable shades of gray to very bright. And you could also see the loss of the RPE as a ring around it. And all of them are better than color imaging or unfortunately, a clinician's exam. So in terms of the ischemic optic neuropathy, what does that look like? So ischemic optic neuropathy is the most common acute optic neuropathy in those older than 50. And with patients with drusen, drusen is actually the most common risk factor for young onset optic dysedema and due to ischemia. The youngest documented in the literature is 7 years old. So, really quite profound. These are people typically who have very little vascular risk factors. They may not have any sleep apnea, very little risk factor other than having optic distrusion and a severe dis at risk. This is a case of a 24-year-old woman with bilateral optic distrusion. You can see the pretty texture on the surface of the optic disc. 2 years after she was initially diagnosed, she developed, unfortunately, new inferior field loss. This is just to compare the left eye visual field on the left, which is the new one, versus the prior. And the image on the right with the yellow highlight is what her nerve looked like now. There is fairly pronounced superior and nasal splinter hemorrhages and swelling that drapes over, kind of like a lava flowing out of a volcano compared to the picture immediately next to it. The diagnosis is ischemic optic neuropathy as a result in association with optic Destrusion. She's only in her 20s. You could see in the white arrow what the drusen look like, which is fairly clear and visible, but in the acute ischemic days is actually harder to see the drusen, and it's true on color imaging as well on autofluorescence imaging. This is a regular ischemic optic neuropathy without optic Destrusion, and you can see it looks swollen, but relatively flat compared to the volcano and the crater, that seems to be of optic Destrusion. So this is a busy figure just to show you all the different modalities: color in the first row, near infrared reflectance, and autofluorescence imaging. And you could really see the difference on the near infrared reflectance of with versus without edema. So with edema, you get this feathery edge. Again, sort of things are, seem like they're flowing out. And then in contrast, the optic disc ischemia without drusen, the optic disc is black on the near infrared reflectance. So really striking difference between the two. And then comparing the before, the during, and the after, you could see the appearance of pallor in column F after ischemic optic neuropathy. The resolution of that raised appearance of the optic disc. So not only is the halo, the lava flowing out of the volcano equivalent, not only is that gone, but the whole optic nerve is actually appearing flatter because you've lost some retinal nerve fiber there, some axons in that area. And you can now see the autofluorescing drusen again on the third row. I'm going to move ahead because I think the near infrared reflectance was actually better illustration. So just to show you the multicolor imaging. So this is something that I started doing mainly because Jeff Goldberg makes sure we have all the best toys in the eye clinic. And so it was there. And so we started taking pictures after doing journal club neuro-ophthalmology. And so essentially, this is, again, pseudo color. And you're seeing the blue, green, and red for the near infrared altogether of 3 different patients with different causes of ischemic optic neuropathy. So the first case is the most severe and arteritic anterior ischemic optic neuropathy in the setting of giant cell arteritis, and then a Moderna COVID-19 vaccine associated ischemic optic neuropathy, a post-cataract extraction AION, and then our patient. So across, you really couldn't see them apart, with this hyper reflectance of the arteries, both on the disc as well as in the peripapillary area. And the main difference you could see is just how raised the drusen AION eye look like. So we wonder, could this be an early marker? We're not sure. So certainly if there's ischemia to the astrocytes along the blood vessels, you're going to get astrocytic changes. This is sort of the basis of gliosis, essentially. But it's probably too good to hope that one imaging modality would be the case. But we're certainly following patients and taking many, many pictures to learn more about this modality. So in summary, high resolution on-phos imaging is routinely and rapidly performed in a busy eye clinic and can provide a lot of information on the size and depth of the optic Destrusion deposits. The green light autofluorescence imaging is the most sensitive, although the blue and the near-infrared reflectance can be quite useful as well. All of them are better than regular color imaging with a white light or a clinician's exam, no matter how good we are and how much time we take, looking at the patient's nerve. The gold standard is, of course, still EDI OCT, so don't forget to do that, especially for the nerve that may appear relatively flat and benign looking. There may be some deposition lurking below, just channeling Stefan's iceberg analogy. Lastly, optic nerve ischemia is the most common cause of acute vision loss in patients with optic Destrusion. They could certainly also have a progressive component using, I think the closest analogy I have is glaucomatous optic neuropathy. Certainly they both localize to the optic nerve head, but much more is needed in order for us to better understand exactly the different mechanisms of vision loss in optic Destrusion. Many thanks to everybody for their support and of course to the patients who were the ones who had to suffer through the pictures. Thank you.
Thanks, Joyce. Any questions?
Joyce, on the some of the first slides where you showed that color fundus photos are useless, I wanted to kind of point out that one, the color fundus camera is extremely prevalent pretty much everywhere.
Yep.
Two, we can take a stereoscopic image and we can see quite a bit of depth. So depth perception is there. I don't know if you looked at that. And third, the color fundus photo actually has 3 channels. So you can look at the blue, the green, and the red and see if there is different sensitivity rather than us sort of disregarding, the usefulness of the color fundus photo. And then lastly, the details that you're seeing may be because of the confocal nature of the near infrared and everything. So there are now confocal color fundus cameras as well. So we could potentially, rather than disregarding the color fundus photo, and since it is so prevalent, and a lot of times if patient comes to you, there are referrals, they may have the color fundus photo rather than the fancy, OCTs and EDIs, et cetera, et cetera. So I was wondering if you have looked into that as well.
Thank you. So more toys to look forward to. Totally agree with Dr. Seppa's comment. I just want to say that, again, Dr. Duba would be mad with me if I don't say that I had the same conversation with him. You can't talk about 3D using a 2D image, although my brain really wants to. So, all these images, the signal is coming from 3D, but I have to be very cautious in terms of interpreting 3D using 2D, so it's kind of like a monocular, depth perception kind of situation. I also want to point out that I think one of the best things we could do is to figure out technology that can move us outside the clinic, so they could be much more readily available and easy to operate. Maybe some of the confocal or the color imaging, but with extra features. I'm looking for things that would be relatively less expensive and easy to operate that we could deploy in the optometrist office or as part of the AI research network. So certainly love to be able to do much, much more. Yeah, so we think that drusen deposits are present in probably something like 2% of the general population, which is actually comparable to the prevalence of glaucoma. We talk about glaucoma all day long, but we don't talk about drusen at all. So we're putting it on the map, and hopefully with, like you said, the easy autofluorescence imaging, that we could really change that. I remember one of the questions that came up last year was, why do people present for a, evaluation at all? And my answer was like, well, they might need glasses, or maybe they got hit on the head. Somebody just needed a screen. But wouldn't it be amazing if we could screen everyone? Because sometimes we see adults who, for the first time, are presenting to us, and for kids, often it's a headache that led to evaluation of papilledema and ended up seeing Dr. Barris.
We'll take one more question.
Regarding the autofluorescence, of course, the challenge is when the drusen are very deeply buried. And just a comment that we did a study once where we've looked at the distance from the inner limiting membrane down to the top of the drusen. And we found a cutoff to be 1.5 millimeters. So if you had a solitary drusen lying below that level, 1.5 millimeter, they were not detected by autofluorescence at all. So I think this is very important, because the situation where you really need to diagnose what is very, very important is the distinction between papilledema and pseudopapilledema in a child. And as I mentioned, 90% of these patients have buried optic distribution, so they're lying very low below the surface, so you won't pick them up by autofluorescence often.
That's a perfect segue to Dr. Barris's talk.